Hello and welcome to the site initiation training video for the ABRUPT trial. ABRUPT is a randomised controlled trial to investigate the clinical and cost effectiveness of amiodarone versus beta blockade for patients with new onset atrial fibrillation whilst in ICU. We are working with protocol version 2 dated the 16th of May 2024. The CI for ABRUPT is Tony Whitehouse, the Deputy CI is Ingeborg Welters, the trial manager is myself, Lisa Holden, the data manager is Kate Brailsford, the sponsor is the University of Birmingham and the funder is the HTA. So the agenda for today, we'll be looking at the background and objectives, the study design, the data management, safety reporting and compliance and conduct. So first of all, let's look at the background and objectives. Atrial fibrillation is a common irregularity of the rhythm of the heart. New onset AF, which is AF never previously diagnosed in a patient, occurs in approximately 5 to 26% of ICU patients, depending on their age, sex, obesity, comorbidities and the reason for their ICU admission. Retrospective studies suggest that patients with NUAF who are treated with the amiodarone have worse outcomes, increased risk of stroke, myocardial events and death than those that are treated with beta blockers. The risk of bias is that sicker patients are treated with amiodarone and so a prospective randomised trial is necessary. ABRUPT is a comparison of amiodarone and beta blockers to establish which management of new onset atrial fibrillation is best to avoid harm and achieve optimal outcomes for patients in ICU. For the purposes of this trial, we will define NOAF as atrial fibrillation lasting for longer than 30 minutes in a patient without a known history of AF. This is whether it was permanent, persistent or paroxysmal. This is important and we ask that you check their medical records to see whether they have any documented history of AF. ICU survivorship leads to chronic ill health, morbidity and mortality. NOAF is also associated with significant ongoing costs in terms of disability, care and treatments. ICU clinicians need to understand the best treatments to apply at the time of critical illness to optimise good survivorship, that is a long and healthy post-ICU recovery. Now let's look at the study design. These are the two interventions used in the ABRUPT trial. Amiodarone is the intervention. The treating clinician can choose the dose, route and the duration, and beta blocker is the comparator. The treating clinician is given the choice of beta blocker to use, the dose and the route. These are the outcomes for ABRUPT. The primary outcome is 90-day mortality and there are a number of secondary outcomes, some relating to safety and some relating to health economics. The inclusion criteria is any adult patient aged 16 years or over in ICU, patients with new onset atrial fibrillation during their acute illness and not known to have had a previous history of AF. This is really important and we ask you to check the patient's medical notes to ensure there is no previous history documented. Patients that will be treated with usual electrolyte management with potassium and magnesium and where there is a clinical indication to treat NOAF. This is a list of the exclusion criteria. Patients with any known previously documented history of AF. Patients who received amiodarone or a beta blocker within the previous 24 hours. Patients with current concomitant medication that are contraindicated with amiodarone or beta blockers. Patients with a serum potassium of less than 4 millimoles. Patients with a serum magnesium value below the index hospital laboratory's lower limit of normal. Patients who have undergone cardiac surgery during their current hospital admission, patients who have been diagnosed with thyrotoxicosis, patients who are going to be withdrawn from life support therapy within 24 hours, patients who have undergone other thoracic surgery that ingresses the thorax, patients with any other known contraindication or known sensitivity to amiodarone or beta blockers, and patients who are known to be pregnant or breastfeeding. Women of childbearing age will be routinely tested for pregnancy as standard of care. Now let's look at recruitment. Patients will initially be identified with new onset atrial fibrillation by their existing clinical care team. As recruitment can occur at any time of the day or night, sites should make efforts to ensure that a system exists whereby patients may be recruited and randomised at any time of the day and any day of the week. Eligibility must be confirmed by a medically qualified member of the research team. The person confirming eligibility must be delegated the duty on the delegation log and must have completed the abrupt training log. Targeted GCP training is available for some roles within the trial, which will provide a brief overview of GCP. The PI and senior research nurse should always have full GCP training though. Screening logs of all eligible patients or legal representatives that have been approached will be completed electronically via REDCap Annex. Now let's look at informed consent. The latest version of informed consent must be completed by the participant or legal representative. Informed consent will be paper-based. These can be uploaded to REDCap, emailed securely to the abrupt mailbox or posted to BCTU. A copy of the ICF must be given to the participant or legal representative, sent to BCTU, filed in the participant's medical notes, and the original ICF must be placed in the investigator site file. As we are using deferred consent, a patient can be recruited without consent being in place, although we ask that some form of consent is in place within 72 hours of randomisation. As this is an emergency care trial, it would be clinically unjustifiable to delay treatment until informed consent can be obtained from a legal representative. If a person or legal representative cannot be identified, we ask the local research team to identify a professional legal representative who is independent of the trial, usually the doctor primarily responsible for the medical treatment of the patient. The legal representative information sheet should be provided and they should be given time to consider the information and have any questions answered before being asked if they are willing to provide consent on behalf of the patient. If face-to-face consent is not possible, remote written consent may be undertaken using the record of telephone declaration form. This will be initialed by the researcher in the presence of a witness and a copy either emailed or posted to the legal representative. An assessment will be made at site to determine whether the patient has regained capacity and is able to consent for themselves. Where this is found to be the case, the patient will be given the patient information sheet to read or have it read to them. Once the patient has had time to read the PIS and ask and have answered any questions, they will be asked if they are willing to give consent to continue participating in the trial. The correct abrupt ICF should be used with the corresponding abrupt information sheet, so the participant information sheet corresponds to the participant ICF. This is an example of participant consent form. Participant consent is ongoing consent to continue in the trial. The legal representative information sheet should be used with the legal representative ICF or the record of telephone declaration. This is an example of the legal representative consent form. And this is an example of the record of telephone declaration. Informed consent and confirmation that the patient is still willing to participate in the trial should always be documented in the patient's notes. Abrupt screening logs will be completed monthly for all eligible patients who are screened. This information will be captured on the REDCap Annex database. The REDCap Annex database is a separate system to the REDCap trial database with separate logins. This is what the screening log will look like. It has a drop-down list for reasons that the patient was not eligible or not recruited. Randomisation will be provided by a secure online randomisation system held at BCTU. Users will be given unique usernames and will set their own password. Usernames and logins are not to be shared. A drop-down list will be built into the database, so only those delegated the duty on the delegation log can perform certain tasks. The system will be available 24 hours a day, 7 days a week. Please see the Abrupt CRF Completion Guidelines document for REDCap user guidance. Randomisation may begin after participant eligibility has been confirmed. A trial number will be provided once a new record is created in REDCap. If data items are missing, randomisation will be suspended but can be restarted once all the information is available. Once fully completed, please then mark the randomisation form as complete. Do not reveal your login details to others as they are unique to each member of staff. With patients and legal representatives' consent, inform the patient's GP of their participation in the trial using the Abrupt Trial GP letter. If you are unable to randomise for whatever reason, please contact the Abrupt Trial office immediately. This is a screenshot of the REDCap database for randomisation and data entry. When you log into the database, select Add Edit Records on the left-hand side and select Add New Record and then Create a New Record. There are more detailed guidelines available in the Abrupt CRF Completion Guidelines document for REDCap user guidance. This is a screenshot of the randomisation form. Note the trial number is in the top left-hand corner. Please enter the trial number onto the ICF. There will be a drop-down list of people who can confirm eligibility based on the roles delegated on the delegation log. Once all the information has been entered, mark the form as complete and select Save and Stay from the drop-down menu for the randomised allocation. There are three options for patient withdrawal. The patient no longer wishes to receive the trial intervention, the participant does not wish to attend trial visits, or the participant is not willing to be followed up in any way. The researcher or legal representative can also withdraw the patient from the trial and/or trial intervention. Please detail any changes in levels of participation in the patient's medical notes and also complete a change of status form. All patients will be included in the analysis on intention to treat basis up to the end point of the trial or to the point where total consent was withdrawn. Now let's look at data handling. Source data will consist of patient data. This is data obtained using the hospital health data system. The participant's medical notes will be the source. Patient reported outcomes. These are obtained from the participant via interview with site research staff and transcribed onto the CRFs, which are then the source data. Clinical event data, for example, electronic or paper medical records. Laboratory results. This will be the original lab result, which may be electronic. Health economics data and withdrawal. Where a patient expresses a wish to withdraw, the conversation must be recorded in the patient's medical notes. This will be the source data. And recruitment. The original record of the randomisation is the source data. CRFs are completed electronically via REDCap by site staff. This is with the exception of SAE forms and pregnancy forms, as these will be paper-based and emailed to the Abrupt Trial mailbox. CRFs are considered complete when all data fields are completed or the data has been marked unobtainable. Validation checks have been incorporated into the REDCap database, and CRFs should be completed as soon as they become due. Please mark the CRF as complete once all data has been entered. The Abrupt Trial team will review all data entered by site staff once a form has been set as complete. The BCTU team will lock the form following review and resolution of all data queries. This is a screenshot of the CRF homepage for participant 10015. The record ID shows you which record you are in. The red indicates that the baseline form is incomplete and all other forms are shown as incomplete or no data saved. The 5 upcoming calendar events will show you when each daily assessment is due. This is an example of the baseline form. The information is to capture the 24 hours prior to randomisation. Once all information has been entered, select Complete at the bottom of the form. In summary, all CRFs are entered directly onto the REDCap database, with the exception of SAE forms and pregnancy forms. SAE forms and pregnancy forms should be emailed to the Abrupt mailbox as soon as possible, within 24 hours of site knowing of the event in the case of SAEs. Any queries generated to address missing or ambiguous data on SAE and pregnancy forms will be emailed directly to the research staff. In summary, the Abrupt Trials team will review the data entered by site staff. Missing and ambiguous data will be queried using data clarification forms within REDCap. Data queries should be resolved by site staff that have been delegated this role on the delegation log, and once all queries have been resolved, the form will be locked by the Abrupt Trials team. To resolve queries that the trial team have generated, select Resolve Queries in the Applications tab on the left-hand side. This will open the data resolution workflow. Correct the issue and complete the data query. The trial team are unable to add or amend or remove data on behalf of sites. calendar in the applications menu details when follow-up forms are due as follows. Data security will be maintained at all times. This will be through physical security measures, limiting access control, through network security measures, system design and management, operational processes, data processing, data protection registration, and system audits. Now we'll look at safety reporting in Abrupt. The definition of a serious adverse event is any event, adverse reaction, or unexpected adverse reaction that results in death, is life-threatening, requires hospitalisation or prolongation of existing hospitalisation, results in persistent or significant disability or incapacity, or consists of a congenital abnormality or birth defect. The frequency of SAEs in this patient population may be high. Many of these SAEs will be anticipated and as such have been protocol defined as expected. These do not need to be reported to the Abrupt Trial Office on an SAE form. They should be reported on the follow-up CRFs and documented in the patient's medical notes.